Hi, this is Yvonne Cook Ojo, and this is for North Central University's MFT 6102 class in psychopathology, diagnosis, and systemic treatment. And this is week 10's discussion um, assignment where I've chosen to film answering the two discussion questions. One being, what key principles should MFTs use to guide their approach to psychopharmacology with clients? And the second question being, how could MFTs take a proactive stance with respect to the limits and benefits of drug therapy? Um, I always apologize for using my notes, for looking off to the side for my notes. But when I was looking at the question, and I'm gonna try my best to get this done in 20 minutes. When I was looking at the questions in regards to pharma psychopharmacological treatments, I have to say that in some way I may be a little biased with the slight prejudice as it relates to psychopharmacological treatments, um, but also in with most prescribed pharmaceutical drugs overall. I don't get me wrong. I am a person who am on prescribed pharmaceutical meds for a medical condition. So I'm one of the millions upon millions of Americans who are currently taking some type of prescribed drug. But when it comes to the pharmacological drugs or the psychotropics, I have a little semi like bias on them. First and foremost, I in many cases I feel that they're highly prescribed. In other words, they're given out to a lot of people, and just from the week's readings, um, there from the week's reading, it actually was stating that in most cases, even our own DSM, pretty much in tandem with managed care, promotes the speedy diagnosis and pharmacological interventions as a cornerstone of treatment. That basically, I think a lot of times everyone wants the quick fix. But even more so, when I looked further into research, and especially in relation to how many people are actually on things just in America alone, I found that nearly 70% of all Americans are at least on some kind of prescribed drug, and more than half are on two or more type of drug. And this is from the Olmsted Medical Center and Mayo Clinic research study. And then further, I asked, or I looked, researched how out of these 70%, the most common prescribed drugs were antibiotics, opioid painkillers, and antidepressants. So then I went further, and if you go further, 1 out of 6 Americans are on some type of psychiatric medication, and that is basically a total of estimated total of 40 million Americans. So 40 million Americans as of December of these numbers are from December of 2016. But 40 million Americans in December of 2016 were on some type of psychiatric medication. If you bring that same 1 out of 6 rating into the population that we currently are at, meaning today's population, that would be 50 million, an estimated 54 million Americans on some type of psychotropic medication. And then out of this group of Americans currently on psychotropic medicines, there is a remarkable number of children and adolescents on these same drugs. And that's kind of, some of these children are prescribed this medication at the tender age of 6. There are even some that are not even 1 years old yet who are being prescribed or put on some type of psychotropic medication. And I'm not saying that psychotropic medications are a total bad, but we know through research that there are a number of different side effects, some side effects that are even harmful to the person, themselves. But of course, it's always you have to weigh the good, if it's the benefit over, does the benefit outweigh the side effect? Okay, that's all good, fine and well. Well, I know, this is what I know, or what I have witnessed. A few things. Number one, as a teacher in the Chicago public system, and I'm talking about African American and Hispanics because this is the population that I deal with. There are a number of children on daily basis getting prescribed on some type of medicine. The rate of the ADHD medicine is just going through the roof. There's so many children on that medicine, it's not even funny. And I watch the side effects of this medicine. I've seen the way that this medicine 9 times out of 10 makes the child. There are some cases where it does what it's supposed to do. Then there's some cases where the drug just totally turns the child into a zombie almost. It's very, very interesting to watch and to see. And then I've also, as a case manager in a psychiatric live-in facility, seen the effects of this drug on the adult population as well. And it's really something to see. And taking all of that into consideration is kind of where I come from with my whole bias about psychotropic medicines. Not that it's a total bad, but just that I feel that we're just, in this nation, that we're just so quick to write a script than to think about what's the best, course, a different course of action, a way to maybe get or wean somebody off of this medicine. Some of this medicine is extremely dependent. I mean, it has a high dependency level to it. And, I can personally vouch for, I remember one time where I was in the hospital and I needed to have a procedure done, and I was like really anxious about the procedure. And so the hospital said, well, you know what, we can give you an anti-anxiety medicine. They gave me Ativan. Well, this was during the time that I was the case manager in the living facility, and I was like, Ativan, are you for real? Like, I've seen people pop Ativan and still be all off the wall. But, they gave me the Ativan, and of course, it worked for me because obviously I was not a person who had been on Ativan every day like the people in the center that I worked at. It worked, and what I realized was like, and I always take that memory with me when I consider other people and have an understanding of what it means to be addicted to something, because the medicine, it just made me have this do not care type attitude. Like what I was going through actually was a spinal tap, and when I tell you that there's, I don't want to say there's a whole lot of pain, but if they like, you can feel it. Okay, let's just put it that way. It's like you can feel like a nerve, like if they hit a nerve, or it's not the best, like procedure that you just want to have done every day or what have you. But what I realized that it was, even though I'm feeling them hurting me, like even though I'm feeling that pain or what have you, my mind was in a state of I don't care. And in any natural situation, the whole point of running from pain is that it's a self-protection mechanism. But on that drug, that self-protection mechanism was off. It was basically turned off. I think somebody could have beat me, and I would have just laid there on that Ativan and left them. And so I really considered that. I really considered this is what other people who are taking or initially taking this drug is going to feel. They're going to have this whole, I don't care. I know it's supposed to make you not anxious, but it also makes you just have this I'm not going to protect myself, don't care type feeling. And so I just wanted to state all of those things, in regards to my sort of bias to the psychopharmacology treatments. However, if the questions, I want to now hit the questions, the key principles that MFTs use, or what key principles should MFTs use to guide their approach to psychopharmacology with clients. I feel the first key principle should guide any health provider is the principle of do no harm. And I feel that this principle and standard that states the client's well-being is this. So I'm sorry, I'm like having issues reading my own notes. This principle, it basically states that the client's well-being is of the utmost importance. And knowing this, I personally think that, understanding that my client's well-being is of the utmost importance, I would present all possible treatments available to my client, and I would state my concerns if I had any. So if a pharmacological or if a psychotropic medication is an option or a better option, or I'm going to present everything. I'm going to present every option and state my concerns if I have any concerns, and assure the client that I will be there working very closely with them in conjunction with whatever psychotropic medication has been prescribed to them, that I will be there in conjunction with that. And that's, of course, if they so choose to take that treatment or that route. How could MFTs take a proactive stance with respect to limitations and benefits of drug therapy? The biggest way to be proactive in regards to the limitations and benefits of drug therapy is to actually know the research behind the limitations. Um, in other words, what are the limitations? What are the benefits? Is there something that we can do that would be useful as a support so that the limitations are not so limited or so limiting? Uh, be mindful of your clients and what their true needs are. Do not be so quick to use a quick fix unless the client is requesting it, and overall take the stance that you will do no harm. Um, if someone is in an extreme critical situation, then we will respond accordingly. I feel that, you respond accordingly. Whatever it is to give relief to that client, we will respond accordingly. And if they are not in an extreme critical situation, then we will respond accordingly. So, overall, I think those are both my answers to the discussion questions. And I just, as I stated in the beginning of this discussion, so I was almost going to say rant, because it kind of sort of felt like that, but I just feel that as a part of the health providing community, that we, like I said, should overall consider what's the best thing for that client. It and like I said, be proactive, know what to expect, like know what to tell the client to expect. I mean, and as our standards, state, we have to respect our own clients' autonomy anyway. If they wish to be on on psychotropic medications, whether we're saying, hey, here's all the side effects, maybe, and then another thing too, a lot of research, and we just kind of talked about this in my last paper that I submitted. A lot of that research was already stating that a lot of times the psychotropic medication alone is not as beneficial anyway. So to pair, I'm one of those people who would be a way better supporter of the conjunction of medicine to psychology, or the therapy, the psychotherapy and medicine. I'm one of those, because I feel that, and I've said this in other papers within this class, that a pill is only addressing symptoms. It's not teaching coping. And a lot of the disorders that we've been talking about, bipolar, schizophrenia, even anxiety, all of those stressors have to do with, all of the things that trigger a lot of the symptoms have to do with stress and coping. And the pill is just going, as I stated, make you feel like, oh, nothing's wrong in the world, is whatever. And it's not going to teach you how to deal with somebody in your family dying all of a sudden, or something really crucial, you losing your job, or any other things that normally happen in life. So overall, I am a big pusher of both the whole conjunction, and really a person being able to talk out that thing, and getting the coping skills down, and that the medicine just helps them be a little less anxious or a little less jumpy as they're sitting there discussing things with you. And that's, in a nutshell, is my discussion. And I said I would get it done in 20 minutes, and I'm about 22 seconds over. So I hope that you enjoyed, and I thank you.